So I'm Professor Mark Little, a consultant interventional radiologist working in Reading and London. I'm also the academic lead within the University Department of Radiology. So genicular artery embolization is a new treatment for osteoarthritis of the knee. It's a completely new way of treating osteoarthritis. Traditionally, patients will be treated conservatively, whether that's with physiotherapy, steroid injections, and then there's a treatment gap before patients are offered knee replacement surgery. Embolization is for those patients who have failed conservative treatments but are not yet severe enough to warrant joint replacement surgery. One of the key factors involved within the progress of osteoarthritis of the knee is that you get these abnormal blood vessels that grow within the lining of the joint. So our role as interventional radiologists is to try and identify these abnormal blood vessels and block them off, because we know that the abnormal blood vessels release factors that cause the pain and can cause the disease to progress. So that's really the theory and rationale behind embolization, is to get into these abnormal blood vessels and block them to get on top of patients' pain. Genicular artery embolization is generally reserved for patients with mild to moderate osteoarthritis of the knee. Most patients, when they come to see us, have already tried physiotherapy. The vast majority will have had a steroid injection in the knee. Some may have even had some other injectables such as PRP. As a general rule, it's probably good practice for patients to have tried at least conservative therapy for 3 months before we work them up for embolization. So we then obviously will perform an X-ray to look at the severity, and in most cases also an MRI scan. And the purpose of the MRI is also to check that the disease is not extremely severe, but also to make sure that there are not other causes of knee pain, which genicular artery embolization will not help with. So it really sits obviously between a steroid injection, which is quick and easy, but generally the long-term data is not great, and a knee replacement, which is obviously fairly binary, much bigger surgery. Genicular artery embolization is a day case procedure. It's minimally invasive, so we gain access to the main artery in the groin through a tiny pinhole incision. From there, we use X-rays where we guide tiny catheters down into the blood vessels of the knee. We then inject contrast under X-rays to light up the knee and see those blood vessels. We're looking for abnormal blood vessels, so-called neovessels or hyperemia. And it's those vessels that release factors that cause pain and cause the osteoarthritis to progress. So we're trying to block those off. We block them off with teeny particles like grains of sand that are around 100 microns. There are risks, as there are with all procedures. So risks of embolization, we've got generic risks of bleeding, infection, pain, damage to vessels and nerves, of which about 1% or less, so low risk. We do see skin discoloration more often than not following the procedure, but it's very much normally self-limiting, goes away in a couple of weeks. What does recovery look like? We need patients to be moving from as soon as they've recovered. So they go back to our interventional radiology recovery bay. They spend 4 hours there. 2 hours flat on the back to enable the groin to heal where we've gone in, and we close the hole just by pressing on it, so no stitches, nothing fancy. And then another 2 hours sat up in bed where they can have a cup of tea. Once we're happy that the groin is fine, they're up and about. We can do lots of fancy measurements of questionnaires or MRIs, but ultimately the best thing is the patient. So if the patient comes back to you at 3-month follow-up and says, actually I can now play tennis, run, pick up my grandkids, that's a marker of success.